It's now my pleasure to move on to another very exciting part of the program, and is to introduce our this year's nominee for the Translating to Medicine Award. This is a special award put forth by Astute Medical Inc. and in memory of one of the colleagues, Jeff Gray. So I'm going to invite to the podium Chris Hibbert, who is the CEO of Astute, to give the award to our recipient this year, who is Dr. Claudio Ronco. So could I invite both Chris and Claudio to be here?
Thank you, Ravi. This is a wonderful occasion. Every year we look forward to this conference, and it's just a pleasure to be here among friends and colleagues. Many years ago, a fellow by the name of Jeff Gray, who was an early member of our team, was also here and attended many of these and was a great contributor to the field. He was a brilliant scientist and a genuinely wonderful man, and we really miss him, and nobody missed him more than his teenage son. And we said, we really need to do something special, something positive to remember what he did and what he stood for. And so Ravi and a number of friends in the audience said we should create an award that looks forward and builds on what was started. And it was all about translating all the great ideas and work and translating that into practice as we move forward. So this year, I'm delighted that the selection committee selected somebody who needs no introduction. When you look at his accomplishments, they're outstanding. Over 1,200 publications, book chapters, early innovations in so many different fields, peritoneal dialysis, neonatal, the wearable technology, biomarkers. He even hosts a conference every year. He goes to hundreds and hundreds of these meetings and presents innovative work. And he still has time to be in a rock band called the Kidney Stones. And I believe he also plays hockey. So I don't know how somebody can accomplish so much and do so much, but we are delighted to be in the presence of what truly is a force of nature. Dr. Claudio Ronco, thank you.
I play hockey, but not very well. Well, thank you very much. Thanks to Astute. Thanks to Ravi. I really feel honored. Jeff Gray was a gentleman and a scholar, and many scientists do accomplish a lot of interesting research and investigation, but only few of them are able to translate this into practice, into everyday patient care. And Jeff was one of those people. And for this reason, I feel particularly privileged to give this lecture in his honor. The human race has been always obsessed by the possibility to predict the future. Will the hunters come back from the hunting campaign? Will the pharaoh in Egypt or ancient Mesopotamia have health time enough to accomplish many things? Female doctors were actually the repository of the future of health of these important patients. The Latin people and the Greek were looking at the birds to understand whether or not the future can be predicted, and this was used by specific priests when people had to go for the gladiators' fight or many other things. And coming to the more recent times, the position of the stars was used to predict the fate of people and their destiny. In ancient Greek, Hippocrates and Asclepius, famous doctors, showed that the equilibrium of life is the foundation of health. And they said we must observe the signs in the fluid produced by the urinary glands, the kidneys. So after that, in Byzantium, they used the matula, which was a transparent container to look at the urine characteristics. And in fact, in this special book on disease, they describe clearly hematuria. Later on, we use the senses to detect signs of disease, like in the case of diabetes insipidus, which means tasteless urine, or mellitus, urine tastes like honey. So the diagnosis comes from the Greek term diagnosein. I'm sorry, I did 8 years of ancient Greek, so I use this sometimes. It is the process toward identification and understanding of a phenomenon through the information derived from signs and symptoms, which is basically the basis from what has been then later the theorem of Thomas Bayes that describes the probability of an event based on prior knowledge. In order to predict, you need to know. So we have the concept, the general concept of semantics, dealing with the meaning of word, and syntax, dealing with the meaning of word in a specific context. How does this apply to acute kidney injury? Well, specifically, if you look at the so-called Semantic Triangle by Charles Ogden, you have an object, you have a concept of the object, and you have signs. Translated into the clinical diagnosis, you have a disease, you have a physician, and you have signs and symptoms. Now, at the beginning of 1900, acute renal failure was diagnosed basically from signs and symptoms, such as oliguria, fatigue, GI bleeding. It was called disorder of the renal glands. Later on, during the bombing of London, Bywaters described cases of acute loss of kidney function in patients injured after the bombing. And these crash victims showed histological evidence for patchy necrosis of renal tubules that allowed us to make the diagnosis of acute tubular necrosis. For a long time, acute tubular necrosis and acute kidney injury were the same thing. Interestingly, the Korean War brought the use of hemodialysis into the so-called meshes, the hospital on the fields, and showed that AKI can be reversible. So the acute concept is the possibility to go back to normal. So how this doctor diagnosed AKI in the past? Well, he simply used the stethoscope that Jean-Louis wants to leave now in the bag. And, however, he also used laboratory medicine. So he used the rising serum creatinine, or he simply looked at the characteristics of the urine output. If we insert this in the semantic triangle, we can say that lab results in the context of clinical setting provide some syntax. They have a meaning when you insert them in a complete picture. And this, in fact, is what happened when you use creatinine to diagnose AKI. Look, more than 30 definitions in the literature. So there is a need of a little more order for this. In fact, this lady says Mr. John Doe in the ward has acute renal failure. She thinks he has a 25% increase in creatinine, while the other guy behind thinks the patient needs renal replacement therapy. There is a little misunderstanding. So how would this doctor diagnose AKI? Well, he got a phone call and he said, I have the Aki group on the phone. They told me to use rifle, Akin or KDIGO. And in fact, this was an attempt, quite successful actually, to categorize and identify specific areas, including urine output and creatinine, that for given specific quantic changes were identified categories of risk, injury, and failure, or simply stage 1, 2, and 3. And these have been validated by a large number of patients, showing that when you move from non-AKI to risk, injury, and failure, or stage 1, 2, and 3, you get worse outcome, right? But this is all based on creatinine. And we all know the limitations of creatinine. Just to tell one, it takes 24, 48 hours creatinine increase when GFR goes down close to zero. So this does not really depict real-time GFR, and it is a filtration marker, but it's a very unreliable filtration marker. Now, sorry, we have a little glitch. So we have now stage 1, 2, and 3, and we know exactly what they mean. But we are missing something, which is what is happening before that. And we know that from a normal epithelium, when you have a kind of injury or an exposure, ischemia, reperfusion, toxicity, you move forward with damage, altered cell metabolism, you have migration of integrins, loss of cell polarization, loss of cell-to-cell adhesion, and exfoliation of cells in the lumen. And then finally you have necrosis, apoptosis, and then you decrease GFR, and finally you increase serum creatinine. So the creatinine clock is always late. And if you go back, oliguria is late. Decrease in GFR may also be late. So how this doctor would diagnose AKI? He looks younger, huh? He says, why not learn it from cardiology? Cardiologists are very good, like the oncologist, to use biomarkers. And biomarkers may actually add to the semantics of the process of clinical and biochemical diagnosis, the syntax of a molecular diagnosis. What is a biomarker? It's a characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacologic response to a therapeutic intervention. It was firstly used in the early 80s, and then it was defined by NIH in 1998. So biomarkers are molecules that are expressed in the moment of damage, or even before, when the cell starts to face a condition of stress. And we have different biomarkers. This is a beautiful article written by Carlton and Marco Cusa, where they describe that we have filtration markers and we have cellular markers or enzymatic markers that can actually be released in the tubular lumen. So this is the example, for example, for KIM1, for NGAL, for interleukin 18, for LFAB. These all molecules depend on specific process occurring at the cellular level and are released or not reabsorbed at the tubular level. And we have a list of these molecules that actually have been described in the literature associated with specific injury or dysfunction. Among those, 3 specific biomarkers are very interesting, NGAL, KIM1, and TIM2 plus multiplied by IGFBP7, which are called cell cycle arrest biomarkers. Why? Because this molecule seems to appear in the moment of the lesion, but they seem also to have an effect on the recovery phase. So these molecules have multiple functions in the early phase and in the late phase. In fact, KIM1, for example, colocalized with markers of the differentiation of the cells, but also of proliferation. And GAL somehow chelate iron, but at the same time delivers iron in the moment of proliferation. And cell cycle arrest biomarkers are very interesting because they are molecules that describe a specific point in the life of cell, in the cell cycle physiology, when DNA damage may actually give a signal and block the replication of the cell. And DAMPs and PAMPs filtered at the tubular level, or reactive oxygen species, or many other molecules may actually activate this process, blocking the cell cycle at the gate 1, allowing not to go on with the damaged DNA. Of course, in the discovery and validation of these molecules, you have to go through experimental validation, analytical performance validation, protocol standardization, and that's why many of these markers have been somehow challenged with specific conditions like healthy subjects, AKI, CKD, urinary tract infection. Some of them have shown limited specificity, I must say. Oh, talking about specificity, people use this sensitivity and specificity to characterize the performance of the biomarker. For example, sensitivity is the percent of patients with disease that display a positive test, while specificity is the percent of patients without disease that display a negative test. But unfortunately, these tests are not really dichotomic. Yes or no. And that's why we use different indexes, such as the Uden index, which show the maximum value for this product. At this point, we built what we call ROC curves. Michael, if you want to answer, there's no problem. But the other important thing is that we use this curve to create the so-called likelihood ratio. And the likelihood ratio is basically something that indicates the probability of the disease in case of a positive test. But look, if you use this nomogram on the right side, you may immediately understand that this depends on the frequency of that disease. If the frequency is very low, then your likelihood can be high, but the capacity of the test to detect and have success in the post-test phase is very limited. So likelihood ratio depends very much on the frequency of the patient. And that's why, for example, in AKI, if you have a low intermediate risk, both high and negative and positive predicted values may be of limited clinical utility, while clinical utility rise up both for low cutoff values and high cutoff values when you are in the high-risk population. And when you are in the very high-risk population, you don't need to predict raining because it is already raining, right? Now, NGAL has shown quite an interesting capability to predict AKI 48 hours before AKI develops, but this was in a very particular environment, young patients, children undergoing cardiac surgery. KIM-1 seems to detect specific lesions induced by ischemia reperfusion. And NephroCheck, which is the product TIM2 by IGF-BP7, seems to overperform all these different biomarkers. And this performance seems to be really specific to detect the risk of developing moderate to severe AKI in the following hours. Now, this has been presented in different papers, and again, you can see how much NephroCheck is capable of doing this. This has also been shown in different cases like administration of platinum-based chemotherapy or in different studies. And this is the most important aspect that show us the different curves that have been obtained by different observational studies in which different cutoff points have been identified. So the concept of cutoff point is that if you start with a very low cutoff, well, the information you can get is very limited or no information. When you try to move to a slightly higher cutoff, you have a large number of negative tests, and again, the specificity may be limited. But when you go up, for example, in this case, at a level of 2, your specificity increases dramatically in the curve, and then when you move forward, the amount of information you can gain is very limited in the ROC curve. So, which patient is at risk for AKI? Well, we have these two cutoff points that are clearly identifying high sensitivity and high specificity, and not only to develop AKI, but also to develop major adverse kidney events at 30 days, including need of dialysis and so on. Other attempts to do specific cutoffs have been used for NGAL, for example, with a little less success, I must say, but still there is information on quantifying and giving a cutoff value in the system. And this gave origin to the concept that AKI is a continuum that goes from a normal kidney to a dead kidney through a series of alterations that goes from stress, increased risk, damage, and then decreased GFR and so on. And every biomarker can actually identify any specific moment. So in the story of AKI, you can have functional changes with no damage, or you can have damage with no functional changes, or you can have actually both. And you can have progression of resolution from every of these specific areas. That's why the Aki group suggested to use functional criteria, creatinine and urine output, but also damage criteria using biomarkers to identify specific conditions. Now, this paper, which has been I think extremely important, showed that people who develop positive biomarker, even in the absence of a clinically developed AKI by creatinine, have the same worse outcome as the AKI patient in terms of need of dialysis and mortality and combined value. So if you have a patient that comes to the emergency room with a chest pain, you make an EKG, and if you have alteration, you diagnose ST elevation myocardial infarction. But if the patient has no EKG alteration, you do troponin, and you diagnose known ST myocardial infarction. At that point, we can say that we have creatinine increased AKI, but we also have, I know you laugh, but we have known creatinine increased AKI. At least if we consider the damage in the kidney and not creatinine as a parameter to diagnose AKI. So in the spectrum of AKI, you have stage 1, 2, and 3, but there is an enormous amount of patients that are in the area of biomarker activation, very high values of biomarker, or what has been called renal angina, when the creatinine change is very slight and not achieving the 0.3 milligram per deciliter, right? So AKI biomarker in the adoption require extended validation. And there are several different studies that have been doing, and the bigger circles show studies with bigger number of patients. But you see the performance is very far from the straight line and flipping a coin. So the capacity to detect the at-risk patient is very high. And this is a kind of meta-analysis recently describing the positive likelihood ratio in case of all these studies. Now, in the adoption line, you always have a gap, which is, yes, now I am convinced, but they cost a lot. So how can I convince my administrators to use that? Health technology assessment is the best answer. This is what we did in our hospital. We said, yes, there is an imperative for health economics, and we need to assess the benefit. So we need to first assess the fact that AKI has associated costs due to immediate care, renal replacement therapy, and so, but also short-term and long-term outcomes. And there are studies that clearly show that in the long term, the possibility to develop other complication different from AKI in patients with high biomarkers and AKI is very high. In our own study, when we did NGAL, for example, we showed that the people in the highest quartile have much higher chance to develop chronic kidney disease. And today we know that many patients with chronic kidney disease come from an episode of AKI, and some of these patients may even require end-stage renal disease and treatment with dialysis. So when you have what we call the kidney attack, which was used, a term used to try to buy people from the cardiology world where the heart attack is so common, we may have complete recovery or partial recovery. But if you have a partial recovery, you end up with a kidney with very high susceptibility, highly susceptible to develop more AKI episodes. Look at this. We have studied patients detecting renal functional reserve in order to understand if renal frailty and incapacity to increase GFR in response to a stimulus were developing more AKI after cardiac surgery. And they did. But what is interesting, that they also developed more subclinical AKI. And what we found later on, 3 months later, was that when you test renal functional reserve, this patient have a reduced renal functional reserve compared to the beginning and pre-treatment. Not only that, also patients who just had increase in biomarkers, they have a significant reduction in renal functional reserve, showing that a damage has occurred to the kidney. A problem has occurred to the kidney, but it did not meet the clinical threshold. So there is a beautiful paper on the Blue Journal published by John Kellum that describes the different modalities the kidney recovers, and we made a commentary to this in the same journal showing that you may have full recovery if you recover your baseline GFR and your renal functional reserve. But if you recover only baseline GFR and not the renal functional reserve, your recovery is apparent. So the main question about biomarker is, fine, now I have the money, I know that they work, can I do something for my patients? Can I avoid progression of AKI? Can I return to a normal condition? And again, John has published this interesting editorial saying the myth of inevitability of AKI is finally shattered. Why? Because he says now the evidence demonstrates that AKI can be prevented, and it is our duty to try to find more ways to do it. So, do you think you are already doing everything? Believe me, this is not true. Maybe at the Erasmus University, maybe in Pittsburgh, but not everywhere. And we have to be more careful in what we do to our patients. And this is the demonstration. The Prevaki trial by Alex Zarbork clearly show that when you apply the KDIGO guidelines for protection of the kidney in presence of a positive biomarker, then you can reduce the number of AKIs and moderate and severe AKI. The same thing is in our own institution. We started what we call the Biomarker Alliance with the clinical chemistry department, and we instituted the nephrology rapid response team. We get the signal immediately on the phone, and we activate what we call the F4 app, which is basically a system that identifies clinical scenario, clinical history, clinical chemistry, biomarkers, and physical examination. And at that point, the checklist and a bundle of actions is instituted. And what we have found is from 1 year to the following year, when we applied this, a significant reduction in the amount of AKIs in ICU and in cardiac surgery, and a significant, extraordinary reduction in the need of renal replacement therapy. So this is the pathway towards adoption of biomarker in our institution. We first went through clinical prediction model, then we evaluated the additional value of biomarkers, then the biomarkers plus the intervention, and finally, this is what we are doing today. We are having a large database. Now we are more than 800 in the database, and patients are categorized by NephroCheck positive and negative, and AKI positive and negative. And there are some interesting information, and we have not completed the examination yet. But certainly, no surprise, the biomarker level is higher in patients who develop AKI. And it's interesting to see that those patients who have a negative biomarker tend to develop AKI in the following days. So maybe there is a need to develop a biomarker curve. And in fact, this is a study that we are doing, showing different trajectories of the biomarker on the day of admission, day 1 and day 2. Also, we studied kidney survival, where kidney survival is better if you have NephroCheck negative. And also we studied kidney survival by admission categories, and we find that NephroCheck is more sensitive as We knew for patients admitted for sepsis, trauma, respiratory disease, patients with high risk. And in fact, the curve moves from very little excitement to a big excitement if you test high-risk patients. So the biomarker is not for every patient. It is for specific patient where you want to test a specific thing. And you have a specific patient survival stratified for the different groups. Now, patients who require CRT, of course, those who have both biomarkers and AKI is the maximum, while the others display different behaviors. Other possibility to use biomarkers in cardiorenal syndrome. Look, many patients develop increasing serum creatinine after 1 or 2 days when they are admitted for acute decompensated heart failure. Why? They receive enormous amount of diuretics, and creatinine rise. But if you follow this with biomarkers, you have the possibility to stop the dangerous intervention. And this is what we have done in some patients. Another thing, if you have 2 different drugs, patient 1 and patient 2, and both drugs do not rise serum creatinine, you can say they are kidney safe. But what if one of the 2 rise the biomarkers? Are you still convinced that they are kidney safe? And in fact, we have a study that we are doing with specific contrast media in patients with very low incidence of creatinine positive AKI, because we want to see if biomarker can be actually an endpoint for our study. We are also studying discontinuation from CRRT, and we have seen in the previous pilot observation that successful discontinuation is in patients with very low levels of biomarker compared to patients that may have higher biomarkers and need to restart CRRT. So we might actually need a series of biomarkers, a combination of biomarkers that identify different moments in the history of AKI, from risk, stress, damage, and so on. But the other thing would be, is there a molecular signature for different types of AKI? Because if this is the case, I could use one specific molecule to identify a toxic AKI rather than ischemia reperfusion and so on. And this would be probably the base for a better intervention in the future, right? For example, also, we need to know if there are biomarkers that identify repair patterns or progression patterns, because we really are interested in trying to make therapies that promote regeneration or recovery of renal function. So in conclusion, I think that the pathway to routine adoption is long, but we can see an expanded use of biomarkers based on different understanding. The routine implementation does not mean to use in everybody. There is a possible role for biomarker combined with the kidney stress test and renal functional reserve. Biomarker may be a trigger for specific action, and they may represent a useful monitoring tool in some conditions, but they may certainly become possible endpoints for clinical trials. In our situation, where we had the clinical model for diagnosis with an ROC of 0.84, we moved to 0.92 by the addition of biomarker. And this is exactly, I just met Alan Meisel outside. He wrote this wonderful paper called Breathing Known Properly. He simply said, how do you diagnose heart failure clinically? And if you use BNP, this is the same thing. How do you diagnose AKI clinically? And if you use the biomarker? So, coming to an end, we have different type of diagnosis, coming from signs, symptoms, physical examination, lab, instrumental, imaging, biochemical, histological, and finally today, molecular, possibly helped in the future by artificial intelligence. So in our semantics and syntax of the diagnosis of AKI, we moved from the science, the 35 definition, the rifle, the KDIGO, going up from clinical to biochemical to cellular identification and finally to molecular diagnosis for AKI. Basically, as it has been said in the past, look at the stars to see the future, and now with the special telescope in the outer space, we can look into the stars. In the past, we were looking at the urine, but now we can look into the urine. To use Winston Churchill word, the AKI word is continuing. Victory is not final, failure is not fatal. It is the courage to continue that counts. And please allow me to wish a wonderful World Kidney Day to all women in this room, because this is a special event today, and I want to celebrate this once more in honor of Jeff Gray. Thank you very much.
Thank you, Claudio, for a superb presentation. Now it's my honor at this stage to actually, one of the things we do at this conference every year is to rate the top-rated abstracts and recognize them for their contribution. So it's my privilege to have Claudio Ronco give the awards to the three recipients. We have, in third place, David Eskenazi. David, are you here? Great, please.
Very good. Congratulations.
Thank you. Thank you. Second place was Jim Tumlin. Jim here. Okay.
I haven't seen it.
And then the top-rated abstract was from Christine Stoops on the Baby Ninja project. Is Christine here? She left. Okay, so David is accepted on behalf of Christine. Right.
You're not going to get the second picture, eh?
Okay, thank you all. For the faculty, please, if you would like, you can pick up your pictures at the desk outside. And again, the lunch sessions are now available, and we will reconvene here for the plenary after lunch. So please go ahead. Thank you. Picture with us.
Chris?